space occupying lesions, and other such conditions. So you can get a gross idea of what should be the possible pathology or possible pathogenesis of the condition depending upon how does it onset and how does it progress. It's important to know if there are any associated complaints with such a condition, whether you have things like headache, vomiting, seizures. The systemic history, like I said, is very important, and particularly pertaining to the neurological system. A family history for hereditary neuropathies, a treatment history of the past, and then let's move on to examination. The most important thing probably is visual acuity, which forms a very important baseline parameter for the future for such patients, and also very often they may come to you with already a reduced visual acuity, so you can on the basis of history get an idea of what the visual acuity earlier was like. So it's important to get an assessment of visual acuity in such cases. Snellen visual acuity, you have to give adequate time to the patient to actually be able to see, because very often they may have scotomas and things like that, and they may have trouble in actually seeing, and if you give them time, they'll be able to read. Alright, always do best corrected, always look for near visual acuity. The next thing is confrontation visual fields. These can give you a good idea, particularly for things like pituitary tumor, or where you've got absolute field defects, for longitudinal field defects like ischemic neuropathies, constricted fields like papilledema, and they also let the patient realize that he does have a field defect. Very often the patient will not realize that at all. And you can always warn him of the dangers of having a field defect, because he could miss targets or objects on one side because of a field defect. The confrontation visual fields are done simply by asking the patient to close his one eye. Let's say he closes his left eye, and from his right eye he looks into the examiner's left eye, who should have closed his other eye, and then you can compare the fields on both sides, or you can bring a target from the periphery to the center and compare the field with yourself. Of course, assuming you're normal. And the pupils, you need to assess the pupil size, the reaction, the near reaction. It's important to look for light reaction, near response. You need to look for RAPD. The general pupillary pathway, and we'll be having a discussion on pupil as well later, consists of an afferent, which is coming to the gingiva nucleus, and then there's an efferent going to the third nerve. The afferent is to the optic nerve. And it's always difficult to measure the pupil size, because there's always a constant change in the size of the pupil. So you could use, the best is to do a diffuse light examination, or you can use the infrared pupillometry, which of course would be the gold standard. And because of the continuous change of size, something called as hippus, it's difficult obviously to get the exact size. But you should always do an examination in both a light and a dark condition. Look for light response, look for near response. The RAPD is very important. The swinging flashlight test, I'll just come to that in a bit, or the Marcus gun pupil, because it gives an idea of the actual involvement of the optic nerve, or in fact the visual pathway. And the patient should be, you have to use a bright light. The patient should be seeing in the far distance, so that there's no near response which is happening. For ocular misalignment, always shine in the visual axis. And what you do generally is you first shine a torch in both the pupils are dilated. You shine a bright torch in the right eye, both constricted. You swing it to the left eye quickly. They remain constricted, that's good. Out here, when you swing it to the left eye, see they dilate. So that means there's a left afferent pupillary defect. The fundus examination is important, and I think I'll quickly run through this. Radhan should tell us. I think a good idea is to do a slit lamp biomicroscopy with a 78 to 90D. Also, you need to do an indirect ophthalmoscopy. There are various parameters in the discs that you need to look for. But I'll come to example. This is what a normal would be looking like, or possibly a retrobulbar neuritis. Papillitis would look something like this. It'll be hyperemic disc with blurred margins. Let's say a toxic optic neuropathy, or you can have a bitemporal pallor in nutritional optic neuropathies. Inflammatory neuropathies may have sometimes peripapillary hemorrhage along with a dilated hyperemic disc. This would be what myelinated nerve fibers looks like. If you get a pallid disc edema, which is differential, think of ischemic neuropathies. This is a case of neuroretinitis, see the macular star. Here you don't get a proper star in papilledema or hypertensive retinopathy. You could get a fan. Basically, this is because of the exudates which have come through the fluid which is leaking from the disc. A primary optic atrophy, well-defined discs, vessels clear. Secondary, ill-defined discs, sheath vessels, dirty-looking disc basically is a secondary optic atrophy. So these are important to differentiate, and we'll come to while discussing them on the disc edema talk. And it's important to know which of these, because the disease that has caused these atrophies is, you get a good indicator by seeing this, that this what could cause this or what could have caused this. There are different differential diagnoses for both of these. Systemically, examination, it's important to do a general systemic examination. CNS is very important. Always look for the cranial nerves, the gait, the motor system, sensory system, and the cerebellar system. Something we often forget to do in practice, because this can give a good idea of where the lesion is. In investigations, the important investigations is color vision, which is fairly important, and typically, let's say neuroophthalmic conditions would cause red-green blindness, and macular would cause blue-yellow, and optic neuritis generally because this is a red desaturation. So even if you don't have this formal testing method, a red object would tend to appear sort of desaturated from the eye, which is having the optic neuritis as compared to the normal eye. Contrast, there are, again, this often gets affected before the visual acuity gets affected and may not completely recover. You can use the Penny-Robson chart, you can use the FACT chart, and there are a lot more charts that are there. Visual fields are important, and they could be automated or they could be manual, static or kinetic. This is a static automated perimetry showing a diffusely depressed field, possibly because of papilledema. This is a kinetic Goldman perimetry showing central scotomas, the same central scotomas seen on the Humphreys visual field, and we'll come to these in specific examples. The VER, and that will be discussed in more detail in another talk, is an important electrophysiological test, which is could be flash or pattern, and it's very important because it gives you an idea of the integrity of the visual system as a whole, right from the optic nerves up to the cortex. And the OCT, the two more, the FFA and the OCT, so the fundus fluorescein angiography, for example, is something we may not need always, but sometimes if you want to confirm a disc leak, neuritis, there are some confusions, you could use it, and especially if there are associated retinal findings that you think that were there. The OCT again is not required so much for diagnosis as it is to follow up patients, and more studies are coming up on the role of OCT in neuro-ophthalmological disorders, in neurological disorders. So these are other investigations that one should now consider in their entire number of investigations. Systemically, it's important to do a hemo. These are the important ones, actually pretty much comprehensive. But and depending on each condition, you have to do this: a hemogram, C-reactive protein, EMA would probably be for autoimmune conditions. This will be for inflammatory conditions. Ischemic neuropathies, you want to be doing a lipid profile, blood sugars, and all. Optic neuritis, neuroretinitis, blood cultures would work. VDRL sensitivities would also be required there. Again, for autoimmune conditions. Radiologically, again, we'll be discussing imaging in another talk in detail. And Montu test is another thing you could conduct because often tuberculosis is something you can find. And often the negative value of a Montu is more than the positive value. So I'm going to stop here.